Good afternoon, everyone, and I welcome you all to the 104th session of e-NISCHIT, which is our initiative to strengthen collaboration between HIV training, HIV and TB through e-learning. So I welcome you all from all the ART centers, and I'm Dr. Ananya. I'm a chest specialist at NITRD, New Delhi, and with me on my panel is Dr. Jyoti from Share India and Rakesh, who will help us with the logistic part. So thank you all for joining. And we begin our session today. Today's session is seems to be a very interesting one because even though we have a rare case, but we are of a foot TB that we would be discussing today. But the problems that the issues and the concerns in this case are something which are very topical and relevant to our everyday practice, that is adherence and to identify extrapulmonary TB and to know what are the red alert signs when we know that we are not going right somewhere, and what investigation do we send when, because extrapulmonary TB, it is a very challenging and a difficult topic, and when it comes to HIV, it just becomes 5 times more difficult. So I'm sure we all will benefit a lot from today's session. So today we have our case presenter, Dr. Gautam Ambedkar from ART Center, Vijayawada, Andhra Pradesh. And I welcome our case presenter. And our expert for today is Dr. Amit Srivastava, Associate Professor, Department of Orthopaedics, UCMS and GTB Delhi. Thank you, sir. Thank you so much, sir, for giving us your precious time. And we are really looking forward to the didactic and learning a lot through that. Thank you, sir. So we will begin our session, and
we request our case presenter to present the case.
Good morning to all. I am Dr. Gautam Ambedkar, Medical Officer, ART Center, OGGH, Vijayawada, madam.
Yeah.
The patient's ART number 11479. She is a female patient, aged about 34 years, and her weight is 45 kgs. Her current weight is 62 kgs. Reason for case presentation: patient diagnosed extrapulmonary TB, recurrent episodes. How to approach if such cases, visits our ART center. Date of ART registration: January 21st, 2020. Date of ART initiation: 29/1/2020. Date of TB confirmation: 23/11/21. Date of ATT initiation: 23/11/21. Type of TB detected: extrapulmonary TB through microbiology and histopathological examination, and through CT scan also. Patient is a staff nurse working in a private hospital, had recurrent episodes of high-grade fever with dry cough, where she underwent investigations, in which she was diagnosed to have extrapulmonary TB, that is TB abdomen, through CT scan in the month of December 2019, and was initiated on ATT in a private clinic. After 1 week of ATT usage, she developed jaundice, and her LFT was deranged further. That's why she was admitted in a private hospital and with a diagnosis of disseminated TB with PUO and ATT-induced hepatitis. Advised to stop ATT and referred to ACTC for HIV testing, where got the positive confirmation of HIV and was linked to ART Center OGGH for further management. Patient was registered at OGGH ART Center on 21/1/2020 and was started on ATT with 4 FDC regimen without knowing the history of jaundice from the patient, and the LFT was deranged again, and her clinical condition worsened and was admitted in a new GGH Vijayawada on 24/1/21 and advised with rifampicin without rifampicin regime, that is isoniazid, pyrazine and ethambutol regimen. She was discharged with HZD ATT regimen and was started on ART with the TLE regimen, where she developed hallucinations and vivid dreams and mixed pills for 1 month, where she consulted private physician and started using TL plus ritonavir with ritonavir. Patient was irregular in ATT and was tracked back to ART center and was continued TLE without disclosing the universal access medicine details and missed ART for 2 months again. Patient then tracked back for second time and underwent USG abdomen and was diagnosed to have extrapulmonary TB, that is TB abdomen, and referred to NTEP for further management, where she didn't use any ATT. In August 2021, patient was substituted with a TLD, and till November 2021, she was started an IPT course in May 2021 and completed her course by November 2021. In the meantime, she developed a pain in her right foot with mild swelling, where the symptoms gradually worsened, and she did not able to walk and underwent X-ray of foot, where navicular bone fracture has been diagnosed and treated conservatively. Patient did not get any relief from pain and swelling, further developed first and consulted Center of Excellence Vijayawada, where she was advised to go for incision and drainage and pus for CBNAT, and was diagnosed to have TB and CBNAT of pus discharge. Advised to start ATT, isoniazid, ethambutol, and pyrazinamide, and she is currently using this ATT. And she had completed ATT. Now, at the time she was using ATT with that regime, and she was substituted with the TLD, and she has been continuing TLD. Her symptoms subsided and able to walk now. With irregular usage of ATT and ART, symptoms even subsided. Her symptoms subsided and able to walk now with regular usage of ATT and ART. A laboratory report, CD4 count at ART initiation 53, that is on 21st 2020. Last three serial counts, CD4 in 2022, April 21st, TND, madam. Next, on 11th, November 7th of November 2023, less than 150 viral load. On 21 January 2020, serum creatinine 1.0, LFT is not there, HB 7 grams, madam, 7 grams per set, WBC 7,600, RBC 2.8 millions, SGPT 38 and SGOT 44. FNS of left supraclavicular lymph node done on 13/11/2020, diagnosed as Corey-Cox-Cold abscess. She was underwent USG abdomen on 27/6/2020 with the diagnosis of grade 1 fatty liver, prominent portal hepatic lymph nodes. USG right foot 24/8/2021, 4 into 3.3 into 1.2 centimeters irregular marginated hypoechoic collection noted in the muscular planes of middle 1/3 of dorsal aspect of right foot with internal air spaces, underlying bone suspicion of abscess partially liquefied, irregular cortical margin, suspicion of abscesses. Partially liquefied. CBNAT of pus discharge from right foot, reforms sensitive. Current regimen, ARNT regimen, TLD, madam. HZD completed. She had been on CPT else. Issue for discussion: iris versus new opportunistic infections. Irregular usage of ATT was the culprit. Navicular fracture of right foot cause.
Thank you for the case and thank you for the case presentation. So before I summarize case also, I have a couple of questions to ask you, if you don't mind, the case presenter, Dr. Gautam Ambedkar ji. First thing I want to ask is that why was she diagnosed as EPTB in the first instance? I mean, because when we talk about 2019 CT chest, it is showing necrotic mediastinal lymph nodes and she had dry cough. Was there an effort to make a, I mean, chest x-ray when she had pulmonary symptoms, and if you have extra pulmonary and pulmonary both, you diagnose it as PTB. So was there any effort to make a pulmonary TB diagnosis there, sir, that we missed? Because she had cough problem and she had chest CT mediastinal necrotic lymph node. She could have been just started on as pulmonary TB. So that's one submission. So this is a case of a 34-year-old female, a nurse, staff nurse, in a private sector. So she had episodes of fever, high-grade fever and dry cough, and she underwent investigation. So apparently her CT chest also showed necrotic mediastinal nodes, and CT abdomen also had nodes. So in general practice and ideal practice, we would label it as PTB because she seems to be having PTB, pulmonary TB symptoms as well from the onset. So anyway, when her ATT was started, she developed jaundice and she was not able to be managed there. So she was referred to the and she got HIV testing done, and there it was a confirmed HIV test positive. And then again when she was started ATT again, given her jaundice had worsened, and because of that, apparently rifampicin was withheld. And when she was given the TLE regimen in ART, she got hallucination. So that's why efavirenz was omitted, and she was given the ezetimibe and ritonavir regimen, and efavirenz was withheld because of her hallucination. So apparently after that, patient, I think, was not motivated enough to take the treatment because it's very easier said than done. And if you go through patient psychology, it is actually very difficult for them to take the medicines. So if they are not motivated or they don't have the will to do it, so she was irregular on ATT and she was irregular on ART as well, and she continued TLE without this. She continued TLE, but she missed her ART for 2 months and maybe for more. Maybe for no more, we don't know. So her her adherence has been quite irregular. So when the patient was tracked the second time, she underwent ultrasound abdomen, and apparently that time also there was a cold abscess of FNAC was done, and there was a cold abscess. So I don't know whether she was enough motivated to get an aspiration done from there, or any microbiological diagnosis, because I'm sure programmatically maybe we may clinically maybe patient we tried, but it depends on the patient how much he is willing to come to the hospital and get the investigation done. So maybe something was missed there, because if there was a cold abscess, aspiration should have definitely been tried, because ultimate goal is microbiological diagnosis. And then what happened is that in August 21, another thing which is little alarming was, then in August 21, patient was substituted with TLD, the normal regimen, the standard regimen that we have. But patient was started on IPT. So which is little alarming, because at that time only her ultrasound right foot report has also been attached. So she started with some symptom of her foot. She started some pain. Obviously that's why that ultrasound foot was done. And when that ultrasound foot was done, it showed hypoechoic collections, and it showed it cortical margins blurring. So when she was showing some foci of tuberculosis, I don't understand why the IPT was started, because then it would have not been the right course. You have to rule out the active TB, and you do never start a prophylactic treatment when you have an active treatment. So her pain in the right, she was started on IPT, and apparently she completed the IPT even though her foot pain was present at the time her IPT started, and her pain and her foot lesion had apparently worsened. And it was only after 4 or 5 months in November that after worsening, her CBNAT sample was taken, and then in CBNAT we could detect the MTB, and the treatment ATT was started then. So I think we missed out in time there, and the diagnosis of ATT could have been made earlier, and IPT should have definitely not started. It's not that you start IPT after ruling out active TB, active pulmonary TB. You start IPT after ruling out TB. So it can be anywhere. So it's not that your chest X-ray is normal, and I don't even know whether the chest X-ray was normal because it's not mentioned. It's not that your chest X-ray is normal and you start the IPT. You have to rule out TB, active TB in every part of in every organ of the body. You have to rule out extrapulmonary TB as well before starting the IPT. So there was a flaw there. So anyway, then after that, the patient was started ATT, and she apparently this time she took the ATT, and began, she responded to it as it seems, because her symptoms had subsided and she was able to walk with the regular use. So what else could have been done, and whether what all we have to keep in our mind, and what right approach is to a case scenario like this. Now we would be learning more of it from our expert today, and I'm very pleased to invite him for the didactic.
Thank you, ma'am, and thank you. I really thank you all for giving me this opportunity. So, as you rightly said, ma'am, this extrapulmonary tuberculosis is not that common, and if we see in extrapulmonary tuberculosis, out of them, the osteoarticular tuberculosis, they also become the incidence become quite less. And they constitute about 8 to 10% of all the and in this also, if we see the foot and ankle tuberculosis, now that is quite rare. Even in our very busy setup in our hospital of GTB hospital, which is where we see a lot of these tuberculosis cases, osteoarticular tuberculosis most commonly is seen in spinal region, followed by the hip, and then the other regions. But foot and ankle tuberculosis is something which is quite rare, and it is seen in around 8 to 10% of all the osteoarticular infection, if I say so. And if we combine all the extrapulmonary infection, it may be 2 to 3%, not more than that. And what we have seen is that in the patient who are HIV positive, the burden of extrapulmonary tuberculosis increases dramatically. It has been seen that it may be in the range of 15 to 20% in HIV negative patients, but it can go up to the rate of 40 to 50% in these patients. So yes, although the foot and ankle incidence is quite low, but in these patients, their presentation can be there, and there can be a little more common than the other population. So the foot and ankle tuberculosis, it can mimic other disorders. So what are the other disorders? I will discuss in my subsequent slides on, and this can be one of the reasons why there is a delay in the treatment, delay in the diagnosis, and thus the further deformity and all those things which happen in these kind of patients. So as we diagnose other cases, in this case also, clinico-radiological diagnosis is very, very important, very pertinent, followed by our other investigations like histopathology, PCR, or CBNAT, which I'm sure you all are much aware than myself. So the most important point is that this disorder can mimic other disorders, which can lead to the diagnostic and therapeutic delays. Can we go to the next slide? Yeah. So the lesion here is classified as osseous or articular. So what do we mean by that? Osseous is something in which mainly the part of the main bone is involved, the shaft of the bone is involved, and the articular is something in which the joint is involvement is there. So depending on the involvement of the area, this has been classified broadly like this, just for the general representation. And when you see these patients clinically, the clinical presentation can be in the form of involvement of the synovium, which is the layer of the articular capsule around the joint. And if not the synovium, then the disease of the main bone or the central bone, which is away from the joint. So these are the two broad disease presentations which happen in these kind of patients. Can I go to the next slide, please? So this is one example here. This is the case of synovitis of the ankle. The patient will just present to you like this, that डॉक्टर साहब यहाँ पे सूजन आ रही है और दर्द हो रहा है, कुछ महीनों से हो रहा है, धीरे धीरे बढ़ रहा है. Otherwise, patient is able to walk. There may be some local rise of temperature. There won't be marked rise in temperature like it happened in other septic arthritis kind of a case, and maybe a doughy kind of soft kind of a swelling. Now, this kind of presentation can happen in tuberculosis also, but these kind of presentation can be seen in some other disorders also, like inflammatory arthritis, rheumatoid arthritis. That may also present like this. So it becomes very important that clinico-radiological as well as other like aspiration cytology and biopsy will be helpful in these kind of patients, so that there is no delay in the treatment of these kind of patients. The other kind of the other spectrum is if the patient does not present to you in the early stages. There may not be the involvement of the joint, there may not be the synovitis, there may be just the involvement of the bone, like the involvement of the metatarsal or involvement of the calcaneum. So low grade infection, there will be just dull aching pain. Patient कहता है हाँ जी डॉक्टर साहब दर्द है, काफी दिन से काम चल रहा है. But suddenly one day there will be a sudden increase in the pain, or the patient may not be able to bear the weight over that limb, or sometimes there can be a sinus discharge which suddenly appears. So these are the two broad spectrum by which the patient presents to your clinic. So when we see the literature and the foot and ankle tuberculosis, as I told you before also, it's not that common. And if we see the bone which is most commonly involved is the calcaneum. Calcaneum, then it is followed by the metatarsals and cuboid and so on. And if we see the joints, the ankle joint is commonly involved, followed by the mid-tarsal joint and the Lisfranc. The Lisfranc joint is basically the second tarso-metatarsal joint, which is so the sequence of involvement is like that. And it has been seen that if we see the pediatric age group, in them the metatarsals are more commonly involved, and in the as we grow on in the children, after the metatarsals, the next commonly involved bone is the ankle joint, and in the adults, basically the calcaneum, talus, and these kind of bones are more commonly involved. Please move to the next slide. Yes. So as I was telling you, in the infants, the metatarsal bone is involved. So this disease process has not spared infants also. It can be seen there also. In children, tarsal bone is involved. And in adults, ankle joint or ankle bone are more common involved, like lateral malleolus, medial malleolus. In older age group, we have seen that calcaneum is found to be more commonly involved than talus. And if we see the joint, then the subtalar joint. Subtalar joint is something which is below the talus and above the calcaneum. In between these two bones, there is a joint which is called subtalar joint. So that is more commonly involved than the other joints. So as the previous presenter told about the case, which was the extrapulmonary presentation of probably the navicular bone, and that patient kept on bearing weight, she kept on walking for 4-5 months, and then started on the suitable treatment. Now, if these patients are not tackled on time, then there can be some serious implications, like these kind of deformities can happen in these kind of patients. This equinus deformity, calcaneus. Equinus means that the foot is like this. It is plantar words. Calcaneus foot is going like this. Then there is an adduction deformity, abduction deformity. I hope you are able to see my myself. So in this, what happens? There is a deviation of the foot on this side. There is a deviation on the foot on the inner side. So these all deformities, they can be prevented if the treatment is started on time and the patient is followed up by the dedicated practitioner who knows what to do in these kind of scenario and how to manage these patients. Most of them, in 90% of my scenario, they can be managed very well conservatively on ATT with the supplementation of some kind of splints. So because if this deformity happens, this leads to a lifelong disability of these kind of patients, and sometimes they are not correctable. Can I go to the next slide? Yeah. So as we all know, in every center in India, whenever a patient presents to us, X-ray is the most basic investigation which we have. But as compared to other regions which are more commonly, the X-rays are more commonly seen, like the X-ray of the chest, X-ray of the hip, pelvis, spine. The foot X-rays are not that commonly visualized, and therefore sometimes the lesions can be missed in the early stages also, sometimes in the later stages also. So it is advisable that whenever a patient comes to you, you get an X-ray of the opposite side of the foot also done. So for the comparison, to see if there is any difference. So what we see in our X-ray, as we see in all other joints, there is a narrowing of the joint space. There is cortical irregularity, and diffuse demineralization of the bone. There is a regional osteopenia which happens. Obviously, when there is a soft tissue abscess, because the abscess is there in the TB, the swollen soft tissue shadows will be seen. And sometimes when there is only involvement of the bone, like here, there's an isolated bone involvement, then there can be a expansion of the bone. This is and sometimes this condition is called spina ventosa, that there is a dilatation of the bone. But this condition also can be, it can be misdiagnosed, and it can be confused with some other conditions, like certain kind of tumors, like anchondromas. They also present like this. So you should be really aware of your clinical radiological, as well as if you need to go for further intervention or something, then you should be aware about that also. Next slide. So now the newer modalities like CT scans and MRI, they have helped us in a big way. There are certain lesions which do not appear in the X-ray, and they are very late presentations. What we have seen that in the presentation in X-ray is delayed by 4 to 6 weeks, or sometimes 2 to 3 months, which we can really pick up early in our MRIs and CT scans. So they have really helped in improving our diagnosis and also starting the treatment as early as possible, so that the patient can have a minimal damage and deformity or disability. So as we see in MRI, there are two kind of sequences, the T1 and T2 images. This is just an example. This is a collection in the calcaneum. This is a osteomyelitis of the calcaneum, tubercular osteomyelitis. These are T2 weighted images where the fluid is hyper intense, and here the fluid is hypo intense. So these are the very early signs of picking up these kind of lesions. Next slide, please. Yeah. But as I told you before, these X-rays, MRI, CT, they all can corroborate with some other clinical features also, some other diagnosis. So you need to be very sure of your diagnosis before starting your treatment. Now it is very clear now with the new TB guidelines that we should have a histopathologically proven diagnosis of tuberculosis before starting the ATT. And as we all know, this is an osteoarticular tuberculosis is a paucibacillary disease. So just like pulmonary tuberculosis, where you are able to find your AFB in your sputum, it may not be possible to find these bacilli. They are usually in the dormant stage or very limited in numbers. So you need to have your these aspiration biopsies. Sometimes it is possible, like we showed that case of synovitis, where you can get the aspiration done and the CBNAT done. Or if it is not possible, do not delay the diagnosis. Go ahead and do the open biopsy and get the sufficient material for the biopsy, because histopathological diagnosis is very pertinent in this condition. So as I was telling you before, these are the various conditions which can mimic the foot and ankle tuberculosis. This is one of case of diabetic foot. This another case of rheumatoid arthritis with trophic ulcers. Then there is another case of calcaneal tumor with swelling. Some biopsy was done somewhere else, now presenting with a sinus kind of a discharge. And another case of mycetoma. So there are, just giving an example, there can be various other examples also, just giving you an overview that do not go with just after this presentation, that if there is a patient with swelling of the foot after he is started on ATT, then he may then definitely it's a case of tuberculosis, and I will start the treatment like that. There can be some other thing associated with that also. So as very well discussed previously also, and I think you in medical management of all these conditions, maybe you people, or all of you are much more aware, much more learned than me in how which kind of regimen to follow. But what we have seen that in osteoarticular tuberculosis, we follow the regimen of the WHO guidelines, that HRZE is given for initially 3 months in osteoarticular tuberculosis and followed by HRE for 9 months. And after 1 year of completion of treatment, we get further MRIs and other things done to reevaluate the patient and see if there are clinical or radiological sign of healing. And if it is there and it has healed completely, there is a replacement of the marrow edema by fat, then we stop the treatment. Till that time, for initial 3 to 4 months, until unless there is no resolution of edema, the patient is given a cast in the form of below knee or below knee cast in the position of function of that patient. So the surgical treatment, as I told you before, it can be as little as aspiration or just the synovial biopsy. And in certain cases, to decrease the disease load, we may need to go for the debridement of the bone also. Sometimes after the residual disease, when the patient is in the painful condition because of the involvement of the articular cartilage of the joint, we need to do the arthrodesis also. That means the fusion of the joint. And in very, very, very rare instances, when it is the condition is completely non-treatable, there are certain cases in which amputation may be required. So this is just an example in which the patient presented here with a sinus discharge over the lateral malleolus, and after completion of the treatment, the sinus is healed. There was a lesion over the lateral malleolus which has healed. And so what are the signs of evidence on the radiology? It's the obliteration of the cavity. There was a cavity here which still some part can be seen here. And now it has been these sclerosis can be seen around it. So the sign of healing which is happening. There is decrease in osteoporosis and restoration of the bony trabeculae, which happens. The elevation or change in ESR, it is a kind of a debatable kind of a thing, but because in many of our cases, we have seen that the clinical radiological improvement has happened in the patient, but sometimes the ESR can can remain persistently at a higher level for a longer time, even like in the range of 40, 50 or something. But I don't think that isolated ESR has any value. So as we are discussing about the ATT with ART in these kind of patient, it has been, as we discussed before, the extrapulmonary tuberculosis is quite common in HIV positive patient cases. But it has been seen that if we start both the treatment, like the patient who is already on ART and we start the patient on ART, there are chances of some paradoxical reactions or IRIS, that is an immune reactivation of the inflammatory syndrome. So the patient might have might not have those symptoms at some place, and there may be certain exacerbation of those symptoms, or there can be some other extrapulmonary symptoms reactivation which can happen. So it has been, there's a NACO guideline also for this, that it has been told that whenever you are starting the ATT in a patient, the ART should be started between 2 weeks to 3 months of the time when you are starting these kind of treatment to prevent these kind of inflammatory reactions. So the IRIS can be of two types, can be paradoxical or unmasking type of IRIS. Paradoxical means there is an inflammatory exacerbation of TB after starting of ATT. Okay. And unmasking TB in which there is exacerbation after starting the ART, in which the ATT has already been started. Then, what I feel is that early diagnosis is quite pertinent in this kind of patient. Patient should have an access to your testing center, the HIV, all those tests. In our osteoarticular tuberculosis cases, we get the ELISA test done for all these patients, right? And the patient should be able to reach to their the diagnosis should be clear from the very beginning. As we were discussing the previous case, the patient was although there was a pain and swelling of the foot, and the patient was started on the IPT therapy, which didn't help her, and the while the tissue procurement and everything was done 4 to 5 months after those things, until that time might some damage might have occurred in that patient. So the bottom line is to start this diagnosis, to diagnose them on time, to start the treatment on time, and to keep the good record keeping, and the follow-up is very, very important in these kind of patients. Thank you.
Thank you, sir. Thank you for making this diagnostic approach so clear and simple, in simple language, so crystal clear to us. So as we understand, it's a very uncommon diagnosis, but because HIV, there's an incidence of extrapulmonary tuberculosis much higher than the normal population, so it might not be so uncommon in HIV population that we deal with. So a couple of questions that coming to my mind is, sir, like when we are sitting in ART centers and this kind of patient comes with just synovitis kind of a picture, what other blood markers or what other systemic examination, what other blood tests we can order to be more go in the line, skew it towards tuberculosis and rule out anything else?
Ma'am, actually, there are no specific blood markers, because if we see, it's basically it's an infection only. So whenever a patient presents to you, or even to us, we will start our treatment. We will get the CBC, ESR, CRP, quantitative CRP, that is done. But as I told you before, there's if their patient is presented to us with synovitis kind of a picture only, then we should rule out some other conditions also, like rheumatoid arthritis. In that case, a thorough clinical examination and history taking is very, very important. And if we see that there are certain other symptoms of other joint involvement, then we get those other tests like RA factor and anti-CCP and other things done for these patients.
Is there anything pathognomic for TB, arthritis, or something which is like clinically nothing? It's just
no, I don't think so, ma'am. No. There is no pathognomic. Although we used to say कि पहले we used to say कि ESR ज़्यादा बढ़ा हुआ है तो TB हो सकता है. We used to discuss these things 10 साल पहले, but अभी ऐसा है नहीं.
And even quantiferon gold, you don't do it.
No, we don't.
That's a good practice, because that we have to do away with.
Yes.
And anything in history, because it's a hematogenous spread. So anything in history like a dental treatment, or how do you, is there any hematogenous spread?
Yeah. So the most common cause can be hematogenous spread, followed by the local spread, which can happen because of the involvement of the nearby joint, and then it spreads to the bone. So the hematogenous spread is the most important cause. So the history taking, which is more important, is the first of all the family history. If the patient himself or herself had any past history of any other kind of pulmonary tuberculosis or any other thing, and that should be there in your history taking.
Okay. So it doesn't mimic septic arthritis patient would be more toxic than a
yes. Where tubercular arthritis, usually they present in your OPD, they are not that toxic. They will be walking, they will be in pain, but they're not that toxic. They're not in that high grade of fever or something. They don't present like that.
Okay, sir. Thank you, sir.
Excuse me, sir.
Yes.
What is the role of MRI scan in diagnosing ortho-related TB?
Yes, sir. So it's a good question. Actually, what we have seen that when the patient presents to you in India, the patient always presents to you a little late. So X-ray, I'm not denying that the X-ray should not be done. X-ray is the basic investigation which should be done. But MRI helps in certain cases in catching these lesions quite early, and also it also helps in diagnosing them and in the follow-up also. Sometimes it happens that in X-rays you are not seeing those complete sign of healing, or the sign of healing also are quite delayed in X-ray. There can be a delay of 3 to 4 months in that also. So if you get the MRI done after the completion of your treatment, you can get the more clear picture, and you can just stop your treatment accordingly.
Okay, sir. Thank you very much.
Yeah, thank you.
So sometimes we're in like a catch-22 situation when we don't know, we are not sure of the diagnosis, and we want to start the ATT. And suppose we start the ATT, would the response in MRI or X-ray tell us, are we on the right track, or should we wait for 1 year and then see? I mean,
what we have seen that actually our main we have a very big large number of data on osteoarticular tuberculosis and tuberculosis spine from our center, and that was the basis of WHO guidelines in which the index TB guidelines was done in 2018. The healing criteria was taken from our publication only. So what we have seen that previously we used to start the treatment without taking any tissues, just on the basis of our clinical this thing and clinical radiological ki haan, ye wahi hoga. But in certain cases we have seen that it has come out to be something else. When the patient did not respond and the biopsy was done, it came out to be some kind of a tumor, like giant cell tumor, or something aneurysmal bone cyst. So in that situation aap thoda sa wo ho jate ho. The situation can be a catch-22 situation at that time. So what I feel that always a histopathology, if you are not able to getting any like aspiration cytology or something is not possible, it is always a good practice to get a good biopsy done. So better to refer the patient and get a biopsy done, and histopathology should be done.
Okay. And so routine follow-up MRIs after 1 year, and X-ray should be in like how many months?
Actually, ma'am, we follow our patient in every first hour after the completion of the intensive therapy. For initial 3 months, we follow the patient. After 6 months, usually the patient's pain and everything they subside quite a bit, and they become quite comfortable. And after the completion of therapy, we do the MRI at 1 year.
Okay, thanks. In case there are no questions, so we will just tell the post-test poll answers. Dr. Jyoti.
So our first question for the pre and post test was, depending on the joint or bone involvement at the presentation, the lesion is classified as osseous, articular, or option C, both A and B. So the correct answer is both the options, osseous and articular. The next question is, which one is not an early sign of inflammation in synovitis? Option A, pain. B was tenderness. C, fever. D, local increase in temperature. E, early dumpy swelling. So the correct answer is C, fever. Fever is not an early sign of inflammation in synovitis.
I have one question from Dr. Alka.
Okay, yeah. So the question is, how long should we give ATT for best prognosis outcome?
So now it's basically it's quite a standard thing now that in our scenario in osteoarticular tuberculosis, we are giving treatment for at least 1 year. We are giving. So that is a standard that we follow in all the cases. And after 1 year, we get the MRI done, be it any area, be it a foot and ankle, be it a wrist, or be it an elbow, or be it a spine. We follow this practice. So 1 year at least.
Yes. Is there any more questions? I'll ask our case presenter if all the queries are being answered.
Anything you want to ask the expert, sir?
No, thanks, madam. Thank you.
So usually TB is bilateral ankle that you see, or you see it's in like localized?
Yes, ma'am. So it's a very good question, ma'am. Actually, this is one of the differentiating features of tuberculosis. If we see from inflammatory arthritis, that in inflammatory arthritis there is symmetrical involvement of the joint. There may be a bilateral ankle along with other areas involved. In the case of these kind of cases, usually they have a unilateral asymmetrical presentation. So most of the time, one joint or one area is involved, but exceptions can always be there.
Thank you. So any last concluding words and something we will remember, ART?
Ma'am, concluding, the most important thing is, whenever the patient is presenting to you, apart from pulmonary, the patient or he or she has these kind of symptoms, please do not hesitate to refer these patients. Refer to the nearest super specialty center or multi-specialist center which you have, so that we do not miss these patients, we do not miss the diagnosis, and avoid the mistreatment and mismanagement of these patients.
So open biopsy, the complications, if they ask us, I mean, risk-benefit ratio is much, it's...
Yes, ma'am. So we always strive, whenever the patient presents to us, if there is always there's a liquid collection or soft tissue collection is there, we try to take the aspiration, maybe like this or by ultrasound guided aspiration. Nowadays, the other modalities are also there, like CT guided biopsies are also quite available. So in our very many spine cases and hip cases, we are going for CT guided biopsy. So they have also a very good yield that can be done. But yes, open biopsy, it has its complication. There are chances of delayed wound healing. Sometimes it does not heal. Chances of sinuses can also be there.
Okay. So that I thank you, sir. Thank you for giving us an excellent attitude today and making the session so memorable. Thank you, sir. And I thank the case presenter also. Thank you, sir, for sharing the case. And I thank everybody, all the participants for joining in today.
Thank you. Thanks a lot. Thank you for the opportunity. Thank you.
Thank you, sir.
Okay, sir. Thank you very much for clarifying your doubts and giving me the opportunity to present the case.
Yes.
Clarifying the doubts also.
Thank you, sir.
Yeah, pleasure,
Thank
sir.
you.
Thank you. Okay, with that we can close the session. Okay, we'll see you. Okay, thank you.
Thank you, sir. I thank all our participants. I thank Dr. Ananya to moderate the session in such a good way. Thank you. Thank you, everyone.
Okay. Thank you.
धन्यवाद.
Dhanyawad.